Let me lower this. So, the first things first, do we have any berry specialists? Like specializing in berries?
I like eating them.
Okay, good. Because if you know the answer, don't answer. But this will be the pseudo least evidence-based part of my talk, berries. And yes, I need to thank Shweta as well. And she couldn't make it because I think it's called a baby. So she's not here. And it's nice, I didn't know we had guests from St. Mike's, so that's very nice. And I was also going to say, if you know Cusimano, he's on this end of the spectrum in terms of intensity. I'm over here somewhere. So there's a huge range between him and I. But great colleague. Okay, snap quiz. Okay, why did I put that up? Okay, what province are we in? BC. Perfect. What are the two most abundant fruit of BC?
Blueberries and cranberries.
Okay, so you're not the blueberry expert? No. So it was a bugger of a time to find out the national fruit of BC. So all I could find was the most abundant, okay? Second one, I am originally from Saskatchewan. What is the most abundant one in Saskatchewan? The Saskatoon berry. But it was like this Supashusha genus Morrisis or whatever it is. I thought Saskatoon was easier. And then finally, we are in the lovely country. I don't have any American data, I apologize. But what is the national fruit of Canada? There it is. So check your sources. I didn't think that was right, but that's the one I found. So long live the blueberry. So this is the breakdown of the talk, and hopefully it breaks down properly, but thanks to this laid-back attitude, it doesn't really matter. The first things first is thank you, as everyone says, and I'm not the expert, and it's colloquial, but it's true, you're the expert. I'm not the expert. I'm just providing information. But we'll do a case. We'll come back to the case to reiterate or reinforce learning principles. I'll give you some facts just to pretend that I studied. And so the twist here was I had a so-called previous speech, but I changed it because I thought I'm going to pretend to have experience in this area, pretend to have seen a bazillion patients, and then to provide guidelines that I think would help. So it's egocentric, but hopefully it's heuristic, if you know what I mean. And then, like I said, we'll come back to the case and questions, and the references aren't included because every talk I go to, they're just like, the guy does it at the end, and you don't hear it. If you need them, just you can get a hold of Deanna if you want, and then we can pass it on, okay? So here we go, a case, just fancy, no face, looks like a guy though. Okay, so there's a person coping with a diagnosis of acromegaly. And this is, the reason I chose the case is when you read about all this stuff, common themes come up. So I incorporated into this case. So it's generally 20, she's 22, I gave that away. Impaired vision, muscle problems, anger problems, self-esteem problems, sleep problems, depression, some suicidal ideation, feeling stigmatized, and anxious regarding her future, feels like a burden to others, and ton of impact in terms of work, and a ton of impact in terms of even family issues and so on. There's a lot of other issues. And you had brought it up, issues related to intimacy and coping. So this could be anyone, but if based on the literature and common things being common, and actually after that last talk, it's massive. So there's a term called illness intrusiveness. Now, illness intrusiveness is it varies, but this is psychologically, if you look at it, there's a lot more illness intrusiveness in this particular realm. But another form of illness intrusiveness is people that have to take medications. Like I think the highest illness intrusive disease, for whatever term you want to use, was cystic fibrosis. They literally can't leave their house because they have so many medications that they would have. We had patients that they had a suitcase that they would take on a fishing trip because for the whole weekend they'd have to have this suitcase of medications just to prevent them. But this is a different, yes, there are medications, but the psychological overlay, I think, is the intrusive element. And it's just not noticed. But again, everyone does have to take medications, and I'm not saying no to that. So there's our case. So just think about it, and we're going to come back to it. And then as a psychiatrist, I'm just giving you ideas of what we do. There's not a hope in whatever that we're going to figure out what to do. But I'm giving you ideas of where we're at in terms of how we think about a case like this when they present to my office, okay? Any questions about the case? Did I miss anything? Like in this large spectrum of stuff? Okay, so if I go quickly, no one can ask me a question. Okay, so everything is as read by me, okay? So you can go find something and read it yourself and say, he's full of it. But not a chance because I'm the guy that read it, so it can't be, no. So this is interesting. The numbers, there's a slight increase in psychiatric disorders. It's not this massive thing where, all of a sudden you've got all these psychiatric. The numbers come in a slight bit over the average, a slight bit over depression, a slight bit over anxiety. It's not through the roof. And that was good to know, but yet obviously you don't want to know that. A third may have depression. That's roughly the numbers in the community, right? A third. 2/3 may have anxiety. Now, this is the one that threw me off. I don't buy that but I'll tell you why. So, depends on the anxiety disorder. So 98% of us have had a panic attack, right? So there's nothing special about having an illness on top of that. They didn't really specify what the actual anxiety is. But if you look at the general presentation of the psychological overlay, and it's not the accurate term, but generalized anxiety. Constant worry, constant inability to move on because they're stuck making decisions, because they're overthinking things, they're overgeneralizing, they're catastrophizing, on and on and on. But so again, I threw it out there because that's what's in the literature. I don't believe it. But, and this is it played itself out. It's more common in younger females, but so is depression and anxiety. And joint issues are increased, and if you have more of them, no brainer or no jointer in this case, of course there's going to be more psychopathology. But I want to change that to psychological distress. People aren't coming into my office because they have full-blown psychiatric disorders because of joint problems. But, again, there is psychological issues that impair their day and their functioning. Okay, we won't even get into that. So, quality of life. It's obvious, and the quality of life is a very difficult marker because it also depends when you catch these people. But if you looked at the questionnaire, it's massive, right? So this quality of life encompasses a very large area. So that's why this talk is impossible for me to do. That's why I said I'm just going to give guidelines, because there's just too many things going on. And if we can come out of here somehow saying you learned something, on those Google reviews or something, just say, oh, we learned something. Or is that for Uber? This was interesting. So two things about the second last thing. There are psychological treatments. The chances of anyone getting those psychological treatments, not too good. Because again, it's so diverse. What I'm trying to say is you take and I'm trying my best to shrink it all so that you can walk away with something. But the interesting thing about psychological issues is there was a study done for patients with rheumatoid arthritis. The number one thing that they found that improved elements of quality of life and psychological wellness was psychoeducation about the illness, about knowing information about the illness, bugging your doctor, figuring it out, and the other thing besides knowing the illness, knowing the prognosis. So in your head, you're clear where you're headed. And that makes sense, right? Like if you know where you're going, it's probably an easier trip. But so that to me was a powerful tool, and I'm glad they spend more time seeing these guys, because it's a great time to answer questions, great time to let people know. And that actually works for if you have friends and family as well, providing them information. So it helps to chat. And then there's small studies for biological treatments. Small. It's not even worth saying, yeah, let's use it. But, that when they talk about depression, there's small ones. And it was mentioned and actually verified that if you get appropriate treatment, you can reduce some of the levels of depression and anxiety, which is great. But there's still all the other stuff. Just because you treated depression doesn't mean that other stuff's going away. And no one mentioned this, but medications can cause side effects, especially when you have the dopamine agonists that are being used for treatment. That's pretty large. There's an 8% chance, and I haven't seen it, 8% chance of someone becoming psychotic. Because if you have too much dopamine on board, then the world gets flipped and everything around you gets flipped. And there's the last one, is if you treat it all, I have no clue what's being done. And I was telling someone, neuroscience hasn't taken the field anywhere, but it has to this point. It alters all of these neurotransmitters. There was one, right, you had mentioned growth hormone. So there are changes with serotonin. So you can get a change by doing treatment. But again, these are talks all on their own. And it's not worth it today. Plus, I'd have to study a lot harder. They'd be boring. More people would fall asleep. Okay, so now we're going to get, questions. Anything before I continue with this diatribe of stuff? Now it works.
So within our groups, many patients have said, along with this disease, causes anger issues.
Yeah.
And some of the medications help regarding the anger issues more than others. I'd like to put out there that recently someone ran into my vehicle, and I like my vehicles. And it wasn't my fault, and they ended up blaming me, but I found myself being unnaturally angry about was a crappy person. And I literally had to, I examined myself, and I ended up going up on my medication, and my anger went down.
Yeah.
And so I can truly attest from what I read throughout our groups that our medications do help. We call it acro rage within our groups.
Yeah.
That it can make a difference.
So I'm going to make comments in two different ways. Of course, get angry, right? Like rip into the guy, do whatever you need to do. But if it becomes, okay, so that's the first comment. So the second comment is the treatment of anger begins with ABCs, which you just did. You look at the antecedents of the behavior, you look at the behavior, and then you decide what are the consequences of that behavior. If those consequences are off the chart, like you're whacking your dog, your kid, whatever, irrespective, that's bad. That's pathological. The source of that is, I don't know. Let's throw in growth hormone or imbalances in that. Of course, that's going to disturb that. But the reflection piece for you, I've only met you for 4 seconds. I'm not thinking you're an angry person, right? So in your baseline is established. If it's off the chart always, then I'd think about that. There is another, last comment, I could keep going for this. I don't like using meds for anger because it's a normal response. But if you find that it's doing that irrespective of the events, yes, then you need some stabilization. And actually, there's geriatric data. Let's take away one of the points on this. If your frontal lobe goes, then Mr. Lizard Brain takes over. What I'm saying, though, is if you strengthen that piece, then the lizard brain, by reflection, the lizard brain doesn't win. And that's when I get worried, is when the bottom is beating the top.
So what's a lizard?
Oh, just the male, like the older part of your brain that allowed us to survive. Like if a dinosaur came, I got to run. And that developed then. Then all of a sudden, the upper lobe decides, I got to design a machine or a gun or a club that'll stop the dinosaur. So then you're growing that to override what would be instinctual. So, and that's what, this is a part of this talk, is to strengthen the frontal. Knowing that there's biological stuff going on all the time that I don't understand fully, but it's still going on. And so that's why I want humans to win versus lizards, I guess. Oh, yeah, go ahead.
I was sleeping.
I was just curious about any of the studies that you were looking at, whether there was a change in the psychological distress of patients, whether patients were working or out of work, like whether they had, or there were students or not, or just recovering at home, like whether there was a difference in the level of psychological distress.
So I can't give you the exact answer for that because I didn't look at the demographics that deeply, but I do know that the earlier you're in therapy or getting treatment for psychological issues, it plays better as you progress. If you get it midlife, which sometimes it happens, then you get stuck, that tradition of it's hard to teach an old dog new. But at the same time, starting earlier always seems to be better in terms of understanding. But yeah, I can't tell you exactly about, but it makes sense psychosocially. If you add multiple stressors, then it's longer to treat, not tougher, but it takes a longer period of time. Okay, so this is, so I'm just, that to my point is, hopefully we can add some stuff to your frontal to override what could be biological, what could be happening underneath it all. So so today I want the psychosocial elements to win as opposed to the biological, which are going on anyways. But again, if you get the biological medications, then we'll move towards psychological things that I think might help you. Okay, so here's the background. And I was writing this, I'm thinking, it sounds like a preacher on but hear me out. This is from experience with patients, okay? A no-brainer. The world's going to impact all of us. Thoughts and emotions are unpredictable. So you can sit here, a neurotransmitter fires and says, depressed. tea sucks, whatever, right? A neurotransmitter fires, and then it just stops. You had no control about whatever thought or emotion showed up, right? So it just goes back. But what keeps that thought and emotion going is the frontal brain saying, oh yeah, you're right, this tea, there's something weird here. Look at the color of the water. You just start building up a system that started off just as a neurotransmitter. It wasn't anything magical. It wasn't anything you could control, but then you drive this little circular thing towards happiness, sadness, mellowness, whatever you want. Theoretically, it's a choice. Not what happened to you first, it's what you do with the stuff. Okay? And that sounds like blaming, but it's the truth. It's not blaming, it's what we do with stuff. And I don't have a clue of why our brains decide to choose to keep doing negative things. There was this theory that if we didn't keep going down the negative thing, the dinosaur would have eaten us. So there's a system in there designed to protect us, but I don't know why it goes so hard on the negative. And it's the same with anxiety, it's the same with trauma. Why do we keep remembering it? Yes, to protect ourselves the next time something like that happens. But then we get comfortable in it, in this loop of negativity, positivity, or nothingness. So, number 2, right. Emotions are blah, blah, blah. I thought that was me talking. So, stuff comes at us. You have 3 choices. I'm going to say it's crap. Doesn't match. I'm going to accept it. Okay, it does match. Or I'm going to take it and I'm going to process it. So, Bhalerao, you're short. Okay, that's what someone might say to me. Okay, fine. I'll accept that I'm short. Okay. Great, I can move on. I could say you're an idiot. You don't know. Depends where you measure me, right? I can do that. But the third thing is, I'm talking people. That wasn't one of those references. Get your mind out of that. But the third is, you know what? If I accept that I'm short, I can choose not to react to someone telling me I'm short. I can also decide to sit with it. And that's the hardest part of all of us, is to be able to sit with stuff, because we all have stuff. But if we're in the business of trying to repair stuff, I think we're wasting our energy. But I believe in trying to repair and understand small stuff. And then eventually the big stuff might figure itself out, but we'll get to that. That's different. And finally, behaviors are permanent or they aren't. So emotions are transient, thoughts are transient, but behaviors can be permanent. Developing a good habit could be permanent. Suicide, bad behavior, that could be permanent. Right? So you get to 2 realms. So you simplify it, okay, do I want to look at my emotions or do I want to look at my behaviors? Or do I want to understand myself? There's 3 big choices, and you have to choose which one's easier. The easiest one, depends who he has, is I think understanding yourself, even though that's a big thing to do. But I'll tell you, we'll see why. Sorry, is this making sense? This is the background. We're getting to the denouement, to the climax. We'll get there eventually. Okay, take small bites. Be realistic. Don't take big chunks, because first of all, your mouth's only a certain size. But don't go bananas trying to do this, okay? We're going to move in. So, as you say, we want to be able to sit with emotions, process them, see patterns if we can. Every single person in this room probably wants to know the answer of where do these patterns come from. Hold your horses. there. So this is where the patterns come from. Parents, abuse, neglect, abandonment, loss, friends, teachers, view of self, view of others, life experiences. So as a shrink, when I do a developmental history, I am listening for this. I'm listening. We ask weird questions. And the reason we're asking weird questions, though, the bottom line, is to see how you yourself cope with stuff. We all regress and we all repeat. If all 100 of us would ever have a cold, we all go backwards. We got to have our mom's cooking. We got to have banana loaf with walnuts. There wasn't any in that. And but we always go backwards to regress. To progress. We regress to progress with patterns that we're used to coping with. That's why understanding what you're doing when you hit a hurdle in your life is huge, because you're going to do the same thing again. Look, if you got kids, if you got family, that dinner table is it's just a regression. That's a pattern that you want to avoid, or you don't, or you do. You know, the turkey tastes better some Christmases if you avoid things. Other Christmases, maybe not. But you know what I'm saying? So there's that pattern within ourselves that comes from this. So don't try to change it. Try to understand it. You can just take a list of stuff. How do I deal with this hurdle? How did I deal with this hurdle? Guaranteed you'll find a pattern. Again, with a therapist, you can take those patterns and utilize cognitive behavioral therapy, interpersonal therapy, a whole bunch of things. But always ask the therapist to have one chunk at a time. I don't want you blabbing. Maybe at the beginning when you're trying to understand, but you want a directed understanding of one or two things. And some therapists have the tendency to let it go. And no one knows what to do when you open up the gates. You know, just make sure you find that. And get help for, again, you can do this on your own, but it does help to have therapy, like to have someone to reflect with it. A partner, a friend, you know, well, a friend who has time, but, and then, like I said, make sure you get help. Okay, and this is the comment. The chances of you getting psychiatric help, forget it. Like 6 to 7 months, and that's why I thought, okay, this talk is sort of relevant, is everyone should go home knowing what they can do, as opposed to, oh, go see someone. And I was glad that, you put me under others. I saw that, all the list of people that help. I saw, so find an other. But it's always tough to find, okay? Okay, questions or concerns? Anything? We're good? Go.
Anybody have any questions?
No? Okay.
No, well, you're not getting off that easy.
Oh, jeez.
So, what did I write down here? I was curious about too much dopamine, 8% increases psychosis.
Yeah.
I want to kind of deep dive into that. So what does that mean? If we're taking too much dopamine, it's going to increase our chances? Like with me, you know what happened, no serotonin,
Yeah.
mental breakdown. So, like, why does that happen to us? Why do we get too much dopamine and end up in psychosis? And why do we get like a crash in serotonin and have a mental breakdown? Like, why does our brains do that?
So the dopamine reference was if any of the endocrinologists use dopamine agonists and like the medications to help lower growth hormone through an indirect mechanism, well, through dopamine, that you can have an increased chance of perceptual disturbances, hearing things, voices, paranoia, you know. Yeah. Yeah. And so but that number, the chances of becoming psychotic in the community on its own is 1% or less. having like schizophrenia or psychosis. That 8% is high. And that's just most likely due to a medication that could be used. And I don't know how often you guys are using dopamine agonists, but
Microphone.
Yeah, we do use them with mild cases because they're not very effective if it's more significant disease, but it's well described, impulse overactivity disorder.
yeah.
So we ask about like gambling and other crazy things that people may do that may be related to the medication. So we always counsel the patient and the family,
Yeah.
and if it's really significant, we stop the medication
Okay.
because we don't want to do harm.
And to your question of why does it fluctuate, okay? That's your body. The right answer is stress causes fluctuations. But here's the 4 pillars that I give to patients that I think we've chatted about in those groups is rest, exercise, routine, and nutrition. That is the simplest thing. But everyone in here, guaranteed, all 4 of those go out of whack when we're under stress.
Yeah.
Guaranteed. And the best thing to do, sort of to the comment about therapy, is that train that's running with rest, exercise, routine, and nutrition, once it goes off the track, the quicker you put it back on the track, the brain does this. That's what it's doing. But when it's under stress, it's like this, and it's just waiting for a chance to, but it gets addicted. If you can get your brain addicted to those 4 things, it'll help way more than worrying about what's my serotonin doing.
Yeah.
Do you know what? Because it's a behavior that your brain gets used to. And you'll see, if all of us know people that are put together, guaranteed those 4 pillars are maintained. But there's also, in the next couple of slides, we'll show you that there are other things that we know about people that are put together besides rest, exercise, routine, and nutrition.
Okay.
Okay?
Yep.
Perfect. Okay. So we're going to focus on coping mechanisms that make us feel like we're put together. Okay? At the beginning, you're going to just kind of look at these things and go, what? But this is borrowed from Mr. Vienna back in the day, smoking, doing his cocaine, lying on his sofa, blah, blah, blah. And his daughter, who came up with elements of what we call coping strategies or defense mechanisms and so on, which still apply till today. And if you can incorporate this into your day, into your life, into your whatever, in addition to understanding yourself, your brain should do a little more should. But no one works at it, right? That's the hardest part. Okay. So so now we're going to talk about good coping mechanisms. So is anyone here altruistic? Okay. Deanna, why don't you have your hand up? You're probably the one. Yeah. Yeah. If you don't understand it, I'll tell you what it is. Yes, exactly. So giving of yourself to other people seems to be very, very therapeutic. Yeah. And there's a sense that it puts you in control, in a sense. It makes you goal-oriented. You need to have rest. You have to incorporate a lot of things to help other people properly. Like I may help a guy on the street by giving him $1. That's nothing out of my day. Compare that to what you do with this entire group. So, therapeutic. But yes, so it's risk rewards, because you're going to put in to get this. The reward is there, and it seems like it's another level of, I don't want to use it like self-realization, they got these old terms, but it's just a part of developing yourself. And it's very interesting. The older you get, everyone says, oh, I should be doing charity work or helping others. But you say that older because transition-wise, you've helped yourself the whole way through. And now it's, oh, how do I give back to my community sort of thing. It's in there, but some people do it earlier. So aestheticism. I don't know. You do it every day in Toronto. People are swearing at you, like I don't know how many times I've been slandered, whatever. But, okay, I get it, buddy. You came from a different world. You came from a different space. There's something cool about you, even though you've called me every racial slur in the book. But you're coming from a good place. It's not my place, but it's the ability to see beauty in others. It doesn't matter who it is or what they do. And again, it's something inherent that you do with your loved ones, but you tend not to do it. I'm just broad, but you tend not to do it under duress, people that you hate, you know. But it is a common thing that, hey, no, there's something good about this guy. I know he's ripping India. Don't talk to me. I don't want to hear you. You know, that's how you respond as opposed to, okay. Sublimation. I hate kids, so guess what I do? I go and coach a kids' hockey team. That's what sublimation is. Like you're taking that stuff, putting it into something else, and I'll tell you this backfired. There's a study that says, you know how these kids are aggressive? They say, oh, get them a punching bag at home. It actually increased their aggression. Yeah, so don't do that. But you sublimate, you take that energy, put it elsewhere, because again, it has to be expended. So why not expend it in a positive manner as opposed to a negative manner? Humor makes sense. The guys that we see, obviously, and I'll tell you the best time we see this is in the hospital, especially on the oncology wards. These people are at the end of their rope. They, again, trying their best to survive, trying their best to be a part of this world. But the easiest ones to treat are the guys or girls that have a sense of humor. They kind of, you walk in, it's a lighthearted, but there's also an understanding of the situation. Yeah, acceptance or I don't know what that is, but it's this, they've probably been like that their whole life. You know, and then they bring it to the table, and it's just something it's comforting to the care, yeah. And so there's a whole literature on what that means in terms of what is it defined as, what's resilience. And the only term I use is whatever works, that makes you resilient without affecting others. But that's my term, but there's a lot of literature on that. And they get vaulted to kind of another level. Man, he's put together, you know. And you'll also see it on the geriatric floor. Demented patients that are angry are horrible to deal with. Demented patients that are humorous and kind, unfortunately, you almost, and again, it's bad to say, but you just feel a little more connected to the less angry ones. But it does happen. There's the 4 pillars, and this is one that I recommend is the venting balloon. So anger, life, self-esteem, this big balloon. If I hold the balloon here and I just let that go and the balloon goes all over the place, right? If I do this, I still got the balloon, but at least I'm getting rid of stuff in an organized manner. And I get, the ones I like is I get relatives to get them to call you guys, anybody, every couple of months and say, 10 minutes, go. It's a one-way conversation. Tell me what's going on. You don't need a therapist. You could, a friend, same thing, a friend, relative, whatever. Just doing it on a regular basis. Because you and I all know we want to blow off steam somewhere. And if you don't do it regularly, the balloon just, and just kind of do that. And a validation hierarchy. Do you guys watch SNL? I think the new one's tonight, actually. The old one, the old people understand this. Who's that? Smalley? Gosh darn it, I'm good enough and people love me. Remember, he looks in the mirror and says that every morning. No joke. You need to have a hierarchy. No one's going to walk around to you and say, hey, what makes you a good person? Oh, I'm honest, compassionate, but no one does that. They just want to know how much of an idiot you are first, and then they'll go. But you yourself have to develop a validation hierarchy. When the train goes off the track, what are your pillars as a person? What are your pillars? Like, well, you know, my life's like this and this. No. What makes you a person? The pillars as a person. And you need to decide in that hierarchy, what are the 10 or 12 things that are important to you? But we all sway away from it. Because no one tells me I'm nice. No, forget it. It's never going to happen. Yes, when you're sick maybe, or you're not doing well. Oh, you're a good mom. You're all this. No, I want to hear that all day, but I'm not going to get it. So be realistic and incorporate it into your own lifestyle. Okay. So same thing, harness them, observe them, so that you're able to change them if you want. Great. I went backwards, sorry. This is what you don't want to do. He's good, she's bad. I'm good, they're bad. Splitting. It's horrible. And it goes against the hierarchy of seeing beauty in everyone. You don't want to devalue because it just brings you to their level. But at the same time, you talk about hormones. When you're ripping into someone, and I don't know the exact anger hormones, but those are up, right? And you don't want to be doing that to yourself. Projecting, I hate myself, I hate them. You don't want to do that. These are all discussions all of their own. Intellectualizing can freeze you. Now, docs are good at doing this, but they call it OCPD, and it's effective. We think things through, or we keep doing. No, intellectualizing can freeze you. You can rethink, think, overthink. Researchers are good at that, and they do good work, though. But don't overthink it if you can help it. Black and white, it's the same thing. You're good, you're bad. Don't cope. I'm not telling you anything new. Using other things. You know, Mr. Trudeau just decided that it's okay to have substances. That's my bias. And then we got Ford having booze everywhere. But the reason I say that is that you're getting into a situation, there's this fake sense of what it takes to stay well. And then that's not of any value. Being trapped in that downward spiral, and I was wondering about a tip for this, and then sometimes I just say use an imaginary stop sign. But don't forget the rule of thumb at this talk, you have to understand what you do. If you start doing it, put up this stop sign in your head. And you'll see it's just a habit. Catch yourself in that trap, put the stop sign up, and crank up the positive coping strategies. Oh, that's the summary of my talk, actually. That's not bad. And quickly, we'll get through it. So the patient that was at the start, there'll be a lot of rambling from me, okay? As I said, so this is how I would see this case, okay? Knowing that acromegaly and psychopathology is higher in females, I would have to be more vigilant at the office. But when it comes to comments like anger and things of that sort, and this comment about the phase of life, so shrinks are always about telling you you're bad, but there's also a part of us that knows what's normal. If you're in a phase of life that requires, contributing to society, then work is going to be an issue. If you're at a stage of life where you're becoming independent, that's just normal. But everyone reframes it as stress. Okay? So we talked about psychoeducation, appropriate medical, yes. So low self-esteem. So comes back to the same thing. Find out where it came from. You'll never find out where. But when your esteem is impacted, try your best to do those 4 pillars and do positive coping strategies as best as possible till it becomes a habit. I put body dysmorphia. They get misdiagnosed as having body dysmorphic syndrome. Oh, there's a part of my body that's not right. You can't have that diagnosis if you have an actual medical diagnosis. So, you have these people that say their nose is out of shape, or if they don't have a disorder, like a medical disorder, then you can diagnose it. So avoid getting misdiagnosed with that. Sleep problems, yes, someone's talking about it. I don't know who's doing it, but don't worry about polysomnography. You just need like 7 questions. Can you fall asleep? Can you stay asleep? Do you snore? Do you have apneic episodes where you don't breathe? Do you sleepwalk? And do you have sleep paralysis? Okay, and then the 7th one is restless leg. Do you have to rub your legs to get to sleep? If you're high on any of those, then you need a polysomnography. And then they can help you beyond that. But you can ask those 8 questions to yourself, and that's the only evidence-based treatment is CBT for insomnia. And it takes a long time to do, and I don't see people finishing it. Depression. Make sure if someone diagnosed you with depression, they qualify the type. Okay, there's seasonal types, there's postpartum, peripartum, because some of them are treated differently and only once. And you talk about inertia. I don't know how many people we inherit. Oh, why are you on this? Oh, my doc told me to stay on it. Okay. Who's your doc? And obviously, the patient that's suicidal, take it seriously. You are not a therapist. You are not a big shot in the house that's going to, if your kid or someone's suicidal, get them to someone. Don't try to second guess what you're going to do. That's just painting a bad picture. A lot of people still do it. But don't think you're going to take on the suicidal family member. Burdening others, you got to change your mindset. There's the balloon. Work issue, she has to apply for all benefits. And that is also a hassle, the amount of claims that you have to do. But again, it gives you the time to breathe and to rest and to do whatever. So don't be ashamed of taking time off work for something they may not understand. And there's the dope acronym. And coping, like I said, that is the summary. Understand, kick into those 4 pillars, and then use appropriate coping strategies. And I think that'll help. I could be wrong. If I'm wrong, don't tell me, because I'm going to keep believing this. And thanks to you again, and I hope you hang around doing this on your own. I hope we've changed the picture a bit and made you feel like you got support. Okay? And thank you.